Okay, why don't we get started? Thank you for attending today's APDA of Massachusetts presentation, Advances in Understanding Deep Brain Stimulation. We look forward to today's presentation. I'll tell you a little bit about how the format will be for today's presentation, and we'll get started. So if you can move to the next slide, please. So my name is Bill Patjane. I'm the Executive Director for the American Parkinson's Disease Association Mass Chapter, and welcome to today's presentation. The APDA of Massachusetts has been in operation for decades and offers programs and services to the PD community in Massachusetts and surrounding states. We've received a very large response to today's presentation. It will be recorded and distributed soon. There's been a tremendous amount of progress in understanding and treating Parkinson's disease. PD is highly individualized from person to person. Not all that is discussed today is relevant to everyone. The healthcare team must be familiar with the signs and symptoms, treatment strategies, and how PD impacts the individual patient. Treating PD well requires a team approach. Today, we are providing information, and this is not intended as medical advice. Next slide, please. So today, the presentation will be delivered in webinar format. So if you have any questions, we will not have the opportunity to ask those questions live. If you have a question, please use the Q&A box, and we'll try to answer as many questions live as we can, and those questions will be answered at the very end. We've got a few questions that have been submitted in advance, and we will start the Q&A section with those questions. So again, if you have any questions during the presentation, please click those in the Q&A button, and we'll get to as many as we can at the very end of today's presentation. I'd like to welcome today's presenters. We have Dr. Ludy Shih and Dr. Pratik Rohatgi presenting today's important topic of DBS, Deep Brain Stimulation. Dr. Ludy Shih is the Associate Professor of Neurology at BU Medical Center. She is board certified in neurology and is fellowship trained in movement disorders. Dr. Shih completed her neurology residency and movement disorder fellowship at Harvard Beth Israel Medical Center and has been involved in DBS since the early phases of DBS's development, working closely with Dr. Daniel Tarsi. Dr. Shih is currently the Neurological Director of Deep Brain Stimulation at Boston Medical Center and is actively engaged in teaching, patient care, and in clinical research. The next presenter will be Dr. Pratik Rohatgi. And Dr. Pratik Rohatgi is the Assistant Professor in Neurosurgery at Boston University Medical Center. He completed his neurosurgery residency at Penn State University, as well as an enfolded fellowship in functional neurosurgery, followed by postgraduate fellowship training in functional neurosurgery at UCLA. He is a graduate of the University of Michigan School of Medicine and has a MS in biomedical engineering with a concentration in neural engineering. Dr. Rohatgi specializes in functional neurosurgery, including deep brain stimulation, surgical treatment of epilepsy, and neuromodulation for pain. And so I'd like to thank each of the presenters, Dr. Shih and Dr. Rohatgi, for today's presentation. Without further ado, I'd like to turn it over to Dr. Shih.
Great. Thank you, Bill, for that very kind introduction. And thank you, everyone, for making it tonight. And for those of you who are watching on the recording, thank you for taking the time to listen. I am always excited about talking about deep brain stimulation because it really has been one of the biggest advances that we've had in medicine and certainly in Parkinson's disease. And we've had a lot of advances in understanding both how DBS might work, but for me, it's been gratifying to see that we are starting to understand how people use deep brain stimulation. And we're going to talk about some innovations and technologies today regarding deep brain stimulation that actually, I think, help people in the sense that they're now able to incorporate it into their life in a more useful and practical way. And so I hope some of the material presented here will help you as you think about this, if you are indeed thinking about deep brain stimulation. So first, I'll go over a few things over the course of this talk. I'll talk about Parkinson's disease itself a little bit, and then we'll go over what actually is DBS, or deep brain stimulation. Dr. Rohatgi will actually give a lot of the background information on deep brain stimulation, and then he'll talk about some of the new DBS technologies. And then we'll jump back in and talk together about the role of a multidisciplinary team when thinking about deep brain stimulation, and the team that makes their recommendations for you and works with you throughout the whole process. And at the end of the talk, there'll be a listing of further resources as well. So first of all, what is Parkinson's disease? Well, depending on who you ask, it's an evolving question, but Parkinson's disease, as we know it, I think, and can be most easily explained as a disorder of the nervous system, both brain, spinal cord, and nerves, that can affect a person's ability to perform common and daily activities. And it does so by causing both motor symptoms, or problems with moving, and non-motor symptoms. And these can include sleep problems, constipation, anxiety, depression, and fatigue, among other symptoms. And again, as you heard earlier, these symptoms do not uniformly affect everyone. And so please, keep that in mind as we talk about these things. We've understood enough now to say that a lot of the motor symptoms are due to a lack of a brain neurotransmitter or chemical called dopamine. And that's very important because a lot of the symptomatic treatments that we have for Parkinson's disease do revolve around the fact that by enhancing or replacing dopamine, we can make a lot of the symptoms better. And what are those motor symptoms? Well, tremor for one, although not everybody with Parkinson's disease has a tremor. Rigidity or stiffness. Bradykinesia is the medical term for slow movement. And postural instability. These can be problems with balance, and they may not occur immediately or right away, but might become more of an issue later on. And then with medication, particularly dopaminergic medications, people with Parkinson's can also develop involuntary movements, in part caused by both having Parkinson's and having dopaminergic medication. It induces changes in the brain that make people predisposed to having these extraneous or unwanted extra movements. And they can look like wiggling or dancing. And sometimes they're not noticeable at all. And sometimes they're really debilitating and uncomfortable. So how might that appear in a person? Well, I have here a few graphs that kind of illustrate in a somewhat of a scientific way how levodopa works over time. So in the leftmost panel, panel A, this might be someone who's just at the beginning stages of Parkinson's. And when they take a dose of their levodopa, their concentrations of levodopa in the blood, meaning they've absorbed the drug, it's working well. They're in this nice sweet spot, this white spot where they're getting good on time. And it may be taking, it might take a few hours and then they'll wear off again. And they'll be in this sort of shaded gray zone where maybe they're not moving quite as well. They have more tremor. Fast forward maybe some time, maybe it's been a few years at least. And now they're getting that same levodopa concentration in their blood. But this time now they're getting into a little bit of that dyskinesia, maybe not a lot, but then wearing off again and maybe getting a little bit more of that slow time or slow or stiff or tremulous time. And then perhaps in some people, and not all, these people will also get into a period of time where they almost all the time they spend in a good on state, they're having a lot of the dyskinesias come with it. And so they have a very small amount of time where they're spending it feeling good in an on state, but without the dyskinesia and not so off, so to speak, slow or stiff. And so this is the problem that some people run into after they've been taking dopaminergic medications and been living with Parkinson's for several years. And I'm now going to turn it over to Dr. Rohatgi, who will explain what we've come up with when people face this situation and others.
Wonderful. Thank you, Ludy, for the kind introduction. So what is deep brain stimulation? It is essentially a technology that is used to help supplement the medications patients are having with Parkinson's disease for better symptom control. So what does that mean in terms of what it is we're actually doing for surgeries? It's an implanted system, and it has three fundamental components. There's an electrode that goes into the brain. There's an extension cable that goes from that electrode into the brain down the back part of the neck and into the area of the collarbone, and is connected to a battery. More commonly now than not, people generally have two electrodes implanted into the brain and one battery implanted just below the collarbone. And there are little plastic caps that are underneath the skin that lock those electrodes in place on the skull. And then for patients, they have a little remote control, which is a patient programmer that allows them to have some flexibility and adjustment. And then the physicians have the industrial version, which allows us much more flexibility in helping adjust the device. Next slide. So the history of neuromodulation is one that actually started quite a long time ago. So the history and foundings of functional neurosurgery, which is really the field of neurosurgery helping to restore function to patients who have some types of disability related to disease, and whether that's related to movement disorders or epilepsy or pain or psychiatric conditions. The foundings of functional neurosurgery are actually related into psychiatric surgery, which initially got a bad reputation because it was a very destructive procedure, and the indications were not particularly good. In the history of Walter Friedman and the frontal lobotomy are ones that will come to mind. But as part of this history, one of the things that the surgeons learned was some patients who had movement disorders, when they had these destructive procedures for psychiatric conditions, their movements actually became more controlled. Over time, that developed and refined to the idea of creating a lesion in the brain. So this was the idea of essentially putting a wire into the brain, heating up a specific area of the brain, and that seemed to calm down the movement disorders patients would have. That peaked into the 60s and 70s, at which time medications became much more popular and used, and Sinemet came to the market, and primary mainstay of treatment became medications rather than an invasive surgical procedure. Although the therapeutic benefit of creating a lesion for movement disorders still has tremendous value. As part of this process for creating a lesion, surgeons noted that they could give patients a test dose of electrical stimulation through the wire that they were going to use to destroy the area of the brain. And they noticed the movements would calm down. And this was hypothesized as early as the 70s and 80s. Maybe we could continually provide electrical stimulation rather than creating a destructive procedure. In the late 80s to 90s, a French neurosurgeon eventually popularized this idea, and the technology had advanced sufficiently enough to create an implanted system, borrowing from the technology of the pacemaker industry, to provide this constant electrical stimulation to the areas of the brain that were previously lesioned. We have several figures up. The first one you can see is the shiny battery, is actually in the early days of pacemaker development, which was the first time these implanted devices were made. And at that time, if you can faintly see, there is a radiation symbol on it. And there was a thought that batteries were not very good. How do we actually get batteries to last the length of life for a patient? And pacemakers are a little bit different than that of DBS, in that if a pacemaker stops functioning, a patient could pass away, which is a little bit different than the nature of DBS. So how do we make those batteries robust was this nuclear battery, which then, as you can imagine, had a whole bunch of ramifications, such as when somebody passes away, how do you deal with it? If they're in an accident, do you need to call like radiation safety people, etc.? So the standard lithium ion batteries that are in everyone's gadgetry now eventually supplanted this. But in 1997, the FDA approved tremor-related Parkinson's disease for implantation in for patients with DBS and also for essential tremor. And then in 2002, it was FDA approval was for advanced Parkinson's disease. And then we fast forward about 15 years or so, and the FDA approves DBS for the approval of advanced or of kind of short duration Parkinson's disease. And by short duration, we're saying symptoms lasting for 4 years with impairing either on and off motor fluctuations, dyskinesias, or tremor. 2016 was also when directional DBS leads came to the market. So this was the first time technology kind of dramatically changed since its introduction. And we'll talk a little bit about that. And in 2022, the ability to record brain activity was incorporated into some of the DBS systems. And this is still under investigation as to whether this will actually mean patients will have a better therapeutic response. And that's still a question that remains unknown. So why do we need advanced technology for DBS? I mean, one thing is functional neurosurgeons are always liking advanced technology. And so that's what makes part of our job fun, is both being technologists and also helping people. But precision is important for DBS. We're working on distances within the millimeters in the brain. So accuracy does matter. What we try to do with DBS surgery is we're implanting the electrode into what we call the sweet spot in the brain. And there are two different areas we implant electrodes in for the treatment of Parkinson's disease. And that's a discussion that both the patients, the movement disorder specialists, and the neurosurgeons have with each patient. Overall, the treatments and benefits are the same, and then there are subtle nuances that would suggest maybe the GPI target versus the STN target. What ends up happening is your surgeon will get MRI studies to physiologically see those structures in your brain. Some surgeons will then go on to do surgery where they put a small electrode in the brain to listen to the brain activity. Some surgeons use just the MRI studies alone to target where those electrodes go to kind of be in that sweet spot of the brain. When we think about why we're doing this to such a degree, we're stimulating an area of the brain. And as we turn on that electricity, we're going to stimulate larger and larger and larger areas of the brain. So invariably, if anyone who has a DBS system is implanted and we turn up the volume to 11, we're going to affect areas of the brain that aren't involved in movement disorders. So the goal is to help patients with the lowest amount of voltage possible. So we're just affecting the areas involved in movement disorders without causing the stimulation to be very large, affecting the other areas of the brain, to give us what we call a large therapeutic window. So kind of speaking to just what I was kind of alluding to. So, the goals and benefits: reduction of tremors, stiffness during those off times, improvement of bradykinesia, hopefully decreasing dyskinesias and dystonia as well. And as I alluded to, side effects of stimulation. So if we increase the amount of brain tissue we're stimulating, things like muscle pooling, facial activation, difficulties in speech, sometimes tingling in an arm or a leg, and paradoxically, sometimes increased dyskinesias can happen. So your surgeons and your movement disorder neurologists are working to give you the best possible benefits and minimizing that risks of side effects, giving us a large therapeutic window early on so that through the course of your disease, we have the most ability to help throughout your life. So innovation one that we'll talk about is directional leads. So traditionally, our electrodes had 4 metal rings on them, and it allowed us to stimulate an electric field like a circle, which allowed us to have good coverage, and we could move that electric field up and down. And this is what the patient and the movement disorder neurologist would spend a lot of time in the office kind of adjusting where that sweet spot is, and as things change over time, making small adjustments and refinements there. In 2016, directional leads came to the market, and instead of having a circle to help activate areas of the brain, we can now basically make ellipse types of areas, kind of steering the electrode field a little bit. And that the goal and intention of that is to have a larger therapeutic window, meaning we can cause improvements of symptoms to the areas we want and not affect the other areas of the brain. It also brings down the amount of electricity we're needing to use for therapy, which will then hopefully increase battery life as well. So the next thing that's come to market as this kind of next generation of DBS devices has come to market is kind of the patient experience. And what do I mean by this? The gadget and gizmo patients get to use to have some degree of control over their DBS device. We can go to the next slide. So, patients, often find that my therapy is ideal for tremor, but sometimes my voice gets a little bit worse. Some patients I want to keep the therapy on during the daytime, but I want to turn it off at nighttime. More commonly for essential tremor patients, sometimes, some of those side effects for stimulation are invariably going to happen as we get therapeutic benefit. And people like to have maybe a higher level of therapy for one set of scenarios in life, and then a different set of therapies for different scenarios in life. So the movement disorder neurologist and the patient can work on different kind of program paradigms for different situations in life. So this is a traditional programmer that everyone got. It's a small little pager-like button. And you have a little bit of interface to it to be able to adjust between different programming modes. Over time, Medtronic has come up with a newer one, which looks like a cell phone. And honestly, there are pros and cons to this. One of the pros is it's much more visual. It's much more what people are used to doing and seeing. There are actually some trade-offs with it. It's like a cell phone. And as everyone knows with their cell phone, their batteries run out. So you have to keep the thing charged much more frequently than the older model. The screen is smooth. There aren't any tactile buttons, which sometimes can be a challenge for people when they're having difficulties with their movements. Next slide. Other two companies have similar things. The Boston Scientific system has buttons on it that are tactile. It's a little newer than kind of that old beeper that we saw, but it kind of reminds you of a cell phone maybe from 10 years ago. But there are some pros and cons with this. It's not a fancy cell phone. It's more like a remote, but it doesn't have the fanciest screen as the cell phone does. And Abbott's programmer is essentially it's an iPhone Touch. It may even be an iPhone now. So again, the same pros and cons. Batteries, let's talk about batteries. Batteries, that discussion has changed over the time. Traditionally, most DBS systems had non-rechargeable batteries, and patients would get their battery replaced every 3 to 5 years. More recently, some companies have come out with rechargeable batteries, and there are pros and cons to both. A non-rechargeable battery is one where you can leave it in your body. You don't have to think about it. You don't have to worry about it. You live out your day-to-day activities. And if you really don't even want to mess with the patient program, you don't have to. And then every 3 to 5 years or so, you'd see your surgeon, and you generally, most surgeons do this the same way. It's an outpatient procedure, and you made a little bit sleepy, a little bit groggy, and the replacement takes about an hour. And then, you get the newest system of the year. The alternative are rechargeable batteries, and they last, generally companies say 15 years or so. And the benefit is you don't have to have surgery for 15 years. Some of the downsides are that you have to charge it. You have to remember to charge it. And generally, I think most people try to counsel patients to charge the device for 1 or 2 hours, every week. It's not that the battery needs to be recharged that frequently, but if you get into that habit, then you're not going to be in a position where, oh my gosh, my battery is very low and I got to get to a charger, or otherwise my whole therapy is going to be off. So that's kind of the counseling that folks get. Another downside of a rechargeable battery is it's the same battery for 15 years, and gadgetry changes over time. So that's certainly a factor to consider, but not necessarily. But a benefit is you don't undergo those surgical risks of a battery replacement, and then the risk of infection happens. 5% is 1 in 20 people, so that's not trivial. You can go on to the next slide. This was essentially what I was just talking through, the rechargeable devices. And this is an example of what the chargers are. Little shawl that sits over the shoulders. Every company's is more or less similar. And you read the paper, watch TV, have breakfast, and patients tell me it's not particularly bothersome, other than the fact that you have to do it. So, and topic 4. So programming can be complex and again take some time to get kind of that sweet spot. And this is, a combination of both your surgeon in implanting the electrodes and then your movement disorder neurologist as well working with you. One of the newest innovations in DBS is also the ability to listen to brain activity, and some of the companies have this as the ability on their battery system as well. When we're in the operating room, some of the surgeons actually listen to single brain cells recording to help us identify that we're in the sweet spot in the brain. But we're looking at, really single cells of neurons activating. What the device is, once they're implanted, they don't have that degree of listening. We kind of listen instead of 10 microns, we listen to the whole field around the electrode as well. And so these devices can listen to some of the brain activity, and there's studies to show that some brain activity areas can be elevated when symptoms are particularly worse. So a thought that's under investigation both in clinical trials and for patients is, one is, can you adjust the DBS in a way to make best use of when we hear that brain activity seems to be more abnormal? And maybe in the future, can we do this in an automated way so the device kind of adjusts itself? So those are studies underway. It's certainly neat. It's certainly exciting. It's certainly a lot to be learned from it. The question still remains, though, whether or not this is going to be beneficial for patients. And then, innovation 4. So remote telemedicine. So this is something as well that companies are working on. It's fancy gadgetry, and as all fancy gadgetry goes, why can't we connect it to the internet? And so a lot of the companies are working on this. And there's a large study in China. There's actually 2 manufacturers in China that are not available in the United States. But as you can imagine, the Chinese healthcare systems is large because of the large population there, and with their very restrictive COVID precautions. A lot of people weren't able to see their physicians, directly for medical care over the last 2 years. And so one of the companies in China created a very extensive telemedicine system to allow patient systems to be completely adjusted by the physician over the internet. And what they found was 90% of people were very happy with that experience. And as you can imagine, if you don't have to go into the medical center, particularly, for patients that are having difficulties with their movements, that this could be very beneficial. So companies in the US are working on this as well. And one of the companies does have this system up and running for patients as well. Go on to the next slide. So, the key hallmark though with all of these things is it's what makes sense for the patient, right? Whether it's directional electrodes versus rechargeable batteries versus which interface to use versus which target to use, it takes a team to treat patients well. And Dr. Shih will talk a little bit more about that.
Thank you, Dr. Rohatgi. So I think we are definitely in this age of enthusiasm for technology, but we all have to remember that the human factor is so important, and people trying to help you make good decisions by giving you information and then trying to apply the technology wisely. I have always found that approach to, I think, generally yield the most satisfying outcomes for everybody. So I definitely want to emphasize that here as you think about this for your own care. And I think it takes a team, and shared decision making is definitely a hallmark of how we like to think about deep brain stimulation, I think, in this day and age. And so while you may interact a lot with your neurologist, who, is often a movement disorder specialist, but doesn't necessarily have to be at the beginning, probably by the time you're thinking about deep brain stimulation, you are talking with someone who is a movement disorder specialist. And an important aspect to this is throughout your journey with Parkinson's, you may already be interacting with some of these people on your team, rehabilitation services, your psychosocial support, including a psychiatrist, a therapist, a social worker, a psychologist. Your primary care clinician is also very important, and there's subspecialists maybe for your other medical conditions that need to be aware, as well as nurses and maybe even a nutritionist you might be working with. And exercise and wellness certainly plays a role all throughout the stages of living with Parkinson's. So we definitely encourage that. And, you know, a tip from us is to ask to talk to people who have gone through DBS and would be willing to share their experience with you. I think that we're all here to help each other. And whenever any of us has experience that they think could help someone, whether it was a good one, it was a bad one, it was I wish I did this differently, or I wish I'd asked about this. You're going to get different perspectives from different people, but it can be helpful to know. And generally, I find our patients who have had it done are more than happy to try to share this, because it's not like everyone in your neighborhood has gone through this kind of experience. So here's the part of the presentation where we'll just mention some of these links to you. You by no means need to write these down. They're available to you. They'll be made available to anyone who would like to have them after the webinar. The APDA has many wonderful sources, both in print and online and on video, as we are doing today. So I encourage you to check out their website, which should have links to all these areas, including just general information about Parkinson's, more information about deep brain stimulation. The National Institutes of Health, our government-funded agency that supports biomedical research, has been instrumental in the development of deep brain stimulation. So there's some interesting history there if you're wanting to learn more. If you want to know more about the nitty-gritty of what happens, or at least in one center, although many centers adopt a similar approach, you can check out our website as an example of how and what happens during DBS consultations. And recently, Dr. Rohatgi and I were asked to guest host a blog post about 5 do's and don'ts on DBS for Parkinson's. So feel free to check that out. And there are some good books out there. Deep Brain Stimulation, A New Life for People with Parkinson's, Dystonia, and Essential Tremor by our good friend and colleague, Dr. Cho, Susan Grube, and Dr. Parag. And check out the community near you. There may be some people who have gone through this and would be willing to speak. Here's that link to that blog, and just a final word of thank you to our team at the Boston University Medical Campus Parkinson's Disease and Movement Disorder Center. Phone number is there. We're on the web and we are on Twitter. So welcome you to find out more information if you're interested. And with that, we will start the question and answer session.
Thank you, doctors. Great presentation today. And we have a few questions for you tonight. The first question is, do you ever have patients who do not want to decide what types of devices to use? And can you help them with this decision?
Yeah, all the time. I would say more than not, patients don't come into meeting me knowing what device to be implanted. I generally frame this in terms of rechargeable batteries versus non-rechargeable batteries and the implications of the lifestyle for patients. My second pass is whether or not they like remote programming options for the future. Only one company is right now fully up and running with that platform. And then thirdly, the concept of brain recording of neural activity. If patients don't have any preference, honestly, most centers tend to gravitate to one company that they're doing most frequently, and that becomes their default system if patients are equivocal.
Good, thank you.
I guess I'll just say, sorry, the systems are more similar than different. So no one should ever feel bad that, oh, I got company A and now company B is here and now company C is there. It's certainly not that way.
Good, thank you. Next question is, how long does it take to get screened for DBS?
I'll take that. I think it can vary from center to center, but because we think it's a good opportunity to meet a few people, sometimes it'll take us, I would say, on the order of 2 or 3 months to help people line up those appointments. And, generally, as Dr. Rohatgi mentioned earlier, a brain MRI is involved, a picture of the brain to take a look. So, but that may vary from place to place. And of course, depends upon how soon, the surgeon's available to do surgery.
Great, thank you. The next question is, are you still in favor of doing DBS earlier?
I think
Who
it's
would like to?
very individual by patient. 4 years is certainly a reasonable time point if symptoms are impairing. That is usually how I counsel patients. So this may be very different than what Dr. Shih will say. But usually if patients tell me that I'm doing great, my medicines are working perfectly, I have no problems, I usually tell them to come back and see me a little later. It's when the medicines are not giving patients the quality of life that they want that I think surgery and the risks of surgery make sense to consider.
Yeah, and I'll just add a similar response. I think, the reasons why, FDA changes indications like this are based on data. And the data came from some trials done in Europe in which they decided to go in a little earlier because, quite frankly, it is true. Sometimes some of our patients are coming to us in a fairly advanced state. And while they'll still benefit from deep brain stimulation, one wonders if they would have enjoyed that benefit or had more time to enjoy that benefit had they come just a little bit earlier. So when you kind of know, if it turns out to be the case for you that you're going to be one of these people who responds well, but now is really, starting to have this up and down phenomenon that is difficult to manage, and also those dyskinesias, I think it's a frank conversation sometimes to say, how much more can I thread the needle with this, and how long do I want to keep trying to do this? And different, it probably frankly depends on just the luck of the draw and how your Parkinson's disease is going to, manifest for you. So in some people, it's within several years. For some people, it can take much longer. So I think having the added flexibility kind of helps everyone just open their mind a little bit and think about just really what's best for the individual situation.
Good, thank you. Another question that we have is concerning DBS surgery in Canada. Do you happen to know the differences between DBS surgery in Canada and in the US?
I don't.
That's the short answer. I was going to say our Canadian colleagues whom we interact with at conferences and so forth, have been some of the real pioneers too in neurosurgery and functional neurosurgery. And, I think every center is going to be similar and different in different ways, but probably like the battery situation, we're probably all more alike than different in most ways. But, the healthcare system is different in Canada in terms of reimbursement and how many people can get deep brain stimulation versus, who's covered here. And so, but if you look on the face of it in terms of our practices worldwide, I think we are often more similar than different.
Yeah, fundamentally, the surgeries are the same. The process of getting to surgery just will vary.
Thank you. Next question is, what is the failure rate of DBS and what are the most common reasons for failure?
I can talk about surgical complications and maybe Dr. Shih can talk a little bit about patients after surgery. So we already discussed, one of the most frequent risk of this procedure is a risk of infection. And we set that as about 5%. Most experienced centers, that number is lower in this day and age. But 5% is non-trivial. It's 1 in 20 people. In general, when people have an infection, it's usually the battery. The common way that that's handled is explanting part of the battery in the electrode, putting people on IV antibiotics for several weeks, making sure after antibiotics are stopped, the infection is still cleared, and then taking people back to surgery to put in a new extension cable and a new battery. Generally, infections don't happen, 1 or 2 days after surgery. They generally start to manifest, a few weeks after surgery, which is kind of a discouraging time point because that's right at the end of the race where the therapy is just being turned on. We're starting to feel good. We've gone through all of these months of getting set up to do surgery, having the initial programming in. Occasionally, the infections can come to the scalp, particularly if people have like skin cancers or other medical comorbidities that may preclude them to different types of infections. Infections in the scalp generally involve removing the entire system, though, because we don't want to have an infection going into the brain. The most scary risk of DBS surgery is, injury to the brain itself. We know that we cause about a 1% risk of any type of bleeding into the brain. That's usually just a little bit of irritation along the pathway of the electrode, which we know because we get CT scans of people. We would never know if we actually saw the person. But a fraction of those people, a fraction of 1% could have a injury to the brain, which could cause, impairment. And there certainly are events of people passing away from the operation. So we certainly, take that in mind and why the recommendations and all of the screening processes for this procedure are taken very seriously. It is an elective brain surgery operation, which in its space is kind of a funny thing to think about. Who'd electively want to have a brain surgery, right? So that's the surgical aspects of things. I'll say something a little, it's going to be flippant, but I'm going to say it anyway. Is one of my faculty members who I trained under answered this question this way. There have been people he's had over years who've been unhappy with how they're doing after deep brain stimulation, but they come back to him every 5 years to get the battery replaced, which means they must be having some benefit, or else why would you?
I'll just say, because I think also probably that question is in part, when doesn't it work? Because we've talked so much about what is supposed to help. And having done this for some time now, I firmly believe it's best to be honest and open. And I ask, what are you really hoping to improve about your Parkinson's or living with it? And give me 3 goals. And I'll tell you really honestly whether I think DBS is the way to achieve those goals, or if it's something else. And so a number of years ago, our friends and colleagues, Dr. Oken at the University of Florida did a nice case series on, and we get these sort of second opinions about people who didn't do so well after DBS and they were operated on elsewhere, and what were some of the problems. And they really boiled down to 3 buckets of problems, which was the surgery itself. It didn't go well. The lead didn't end up in the right place, or there was a complication. Complications, I will say, just to add on to Dr. Rohatgi, he's very conscientious that people know about the risks, but I don't think DBS would have taken off the way it did if it weren't for the fact that we've had a fairly low complication rate with respect to, all the surgeries that are out there that one can do in the world. So there is that. The second bucket tends to be the diagnosis. Was the diagnosis right? Was it the right time? Was the right expectation laid out about why the procedure is being done? And then the third bucket was the programming. There were maybe some ways in which their DBS was programmed that, didn't really lead to a good therapeutic benefit. And by revisiting some things there and changing some things around, people were able to improve quite a bit. So, this is why we're really careful about, getting to know people and what's their goal for surgery. And I think you can really cut down on this, in this sort of, quote unquote DBS failure. So I will say, I tend to think it's a pretty low rate of quote unquote failure. And I think people have, as long as they know what their goals are and what the DBS really can do and what it can't do, then I think we're all on the same page.
Good, thank you. Next question is, if I don't have dyskinesia, will the DBS prove helpful?
Yeah, some people don't have a lot of dyskinesia. The other big reason to do it, I think of, is any extra movements. So tremor can be a big one, and it can be actually kind of stubborn and resistant to medications. That doesn't mean you don't have Parkinson's. Some people have heard, well, if you don't respond to medication, must mean you don't have Parkinson's. You have something else. That's probably, I mean, is essentially tremor is sort of the exception to that rule. You can have a very stubborn and resistant tremor that does very well with DBS. So, and then the other thing to say is people who do have a lot of clear response to medication, where they're quicker, looser, can move better on medication, and as they wear off, it all comes back again. That's someone who I think is having a motor complication, which is a motor fluctuation that goes on and off. And I think that can improve as well.
Good, thank you. The next question I have is a fairly long question. If you have tremors on your left side and get DBS with the electrode specifically placed and programmed based on the left side tremors, and then the tremors start on the right side, do you have to have more surgery to be able to reposition or reprogram the electrodes to accommodate the new right side tremors? Or since you have 8 places on the electrode, can you just turn on the areas that were not originally programmed?
Yeah, I can answer this. So when we treat patients with deep brain stimulation, a general concept, in brain anatomy is the left side of the brain controls the right side of the body, right side of the brain controls the left side of the body. So when we put an electrode in on one side of the brain, regardless of whether we turn the voltage to 1 or crank it up to 11, as I'm jokingly saying, it's only going to affect one side of the body. So to treat the other side of the body, you would need to put an electrode in on the other side. Now, that being said, a lot of people find that if you treat their dominant side, that is sufficient and quite a bit more beneficial than them saying, well, I'm only half treated. So the happiness of somebody isn't half if they've only had one side of the body treated, if that helps answer that question.
Good, thank you. Next question is, does DBS affect freezing of gait, festination?
Great question. And a lot of people want to know the answer to this. The answer is sometimes it can improve it. The answer is also, we've observed that sometimes DBS can worsen it. And there's a tremendous amount of scientific interest as to why this is the case. So some people are focused on trying to re-engineer the DBS based on electrophysiological signals that can somehow interpret what's happening when people are walking. Other people are doing research focused on, well, why does freezing of gait happen in the first place? And is it always that very location in the brain that's worth fixing, or so to speak, or stimulating to fix the problem? So I think the answer is we don't know yet, but everyone's sort of focused on finding ways to improve freezing of gait, whether it's through some technical advancement in DBS or through DBS means. Maybe there'll be some other advances in therapeutics that will be useful for that.
Good, thank you. Next question I have, if the lead location is slightly off the mark, how does that get resolved, and can programming overcome this problem?
So programming can, to some degree, and the directionality of these newer leads allows a little bit more of that to some degree. But if it's fundamentally not in the ideal spot, then a surgical revision would be required. So in general, we work with programming, trying to get that electrode into the ideal programming situation as possible. And if we feel like this is not quite what we need, then we think about potentially revising the electrode.
Good, thank you. The next question we have is around coverage of the surgery, DBS. generally speaking, can you speak a little bit about insurance and Medicare coverage?
It's covered. That's as much as I can honestly answer.
Yeah. Good. Is the decrease in the frequency and dose a given? That is the marketing hook. I have the reverse experience, is what the person said.
Yeah, and if I assuming correctly here, the person's referring to decreasing the dose and frequency of their Parkinson's medications, the dopaminergic medications. Yeah, in my
Yes.
experience, the clinical trials shown that for a lot of people, they can reduce their medication. But in practice, and I think others, my colleagues would agree, I have the experience that the person may stay on the same regimen of medications, but they work a little bit better now because what's running in the background of all this, medication up and down is the DBS is running 24 hours a day, 7 days a week. So I don't advise people to get too hung up on it. Sometimes people are looking to reduce medications because they're causing some other kind of unwanted side effects. And so that requires a little bit of talking through what are the various options to improve that anyways, irrespective of whether someone has DBS. And yes, I mean, over time, some people find that as their Parkinson's, we didn't really get to this point, but DBS doesn't slow down, so to speak, the progression of Parkinson's, and so some symptoms will continue to get worse with time. And I have found that some patients still find it useful, levodopa or the dopaminergic medications still do something a little bit different than what DBS does. So I think that you see these patterns playing out in people who have had DBS for PD.
Good, thank you. Thank you for mentioning the team involved in care. I think it's incredibly important. Do you ever care for patients not close to a DBS center?
Sorry, your voice cut out just a little bit. Do we ever care for patients who
are not close to a DBS center?
Oh, great question. So yes, there's ways to do it. And both Dr. Rohatgi and I are, often asked to see a patient who's from out of state or even out of the country. And it can happen. It just requires a bit of coordination. Obviously, although the programming we've talked about being somewhat remote, the first part of it really should be done in person. And then, of course, the surgery definitely has to be done in person. But there have been some innovative ways to do, telemedicine consultation. Really, frankly, from out of state, we're seeing now that, it's still best to come in person. And more DBS centers are popping up in areas of the country, especially in the middle of the country. You can go for hundreds of miles without running into a center that can do this, but it is becoming, there are more and more people getting trained in this. And so it is becoming more common. But yeah, I think that's the best advice I can give is if you don't know if you live close to a DBS center, the various Parkinson's disease associations like the APDA can be, I think, helpful resources. Each state, if I'm not mistaken, or close to it has a chapter of information, and they could also help you sort out where might be the closest place to go.
And another thing I'll kind of add to that is, as being as somebody who's from the middle of the country, is that patients can often come to a DBS center for their initial surgeries, their initial programmings, and then their local neurologist, who's the person who's made that diagnosis and helping the patients with Parkinson's disease, follows with all the subsequent care. And then, if you need to have that battery replaced in 3 to 5 years, you come back to the big center for that change, and then the local neurologist can manage the patients as well. So it's not that you have to go to the big ivory tower places 100% of the time as soon as you have DBS and your local team kind of gets abandoned. It's generally not that case.
Good. And so that's all that we have today for questions. I want to thank Dr. Rohatgi and Dr. Shih for a great presentation. As I said earlier, we'll have this up on our YouTube page, and we will distribute it to everybody that not only attended the session today, but also registered. Just a few additional things. Here in Massachusetts, we have an information referral center. Along with the email, I'll send a link to the YouTube as well as information about the information referral center, where our two presenters are located. It's at Boston University Medical Campus. The phone number is 617-638-8466. Here in Massachusetts, we have education and support groups. We additionally have health and wellness programs, not only in Massachusetts, all around the country. As Dr. Shih mentioned earlier, the APDA of Massachusetts, as well as other chapters, are on social media. We're on Facebook, Twitter, Instagram, as well as YouTube. And so again, I'd like to thank our two presenters today. I think we were able to get through most of the questions today. Thank you very much for a very thorough presentation, and thank you for your support of not only the APDA, but of the PD community. And we very much appreciate it. So thank you and have a great night.
Thank you. And
Thank
good night,
you. Good
everyone.
evening, everyone.
Thank you.